It's not influenza, so it is bacteria. We have a vaccine against it. It is in the regular schedule for infants. So I don't know how many they get, either 1 or 3.
I think it's 3.
3, probably several months apart. So those are different. They are not synonymous, bacterial versus viral. Did you all talk about treatment of TB?
Yes.
Okay, I could not tell that from his slide set.
It was kind of all over.
Yeah.
Okay. I've organized it around treatment of latent and active, and then we'll talk about initial versus continuous in the active. So, and I'll spend a lot of time on drug. I'm also going to show you drug interaction program, just so you'll know what to expect from them.
Could you reiterate what latent and active means? You kind of tried, but
Okay, well, if you look on the bottom of page, mine is going to be a little bit different from yours. The second page, I guess, under treatment of latent TB in adults. Okay. So at the very beginning, I give it to you. Latent means they've got the bug inside them. It's just not active. So latent always means inactive. A presence that's not doing anything is latent. Okay. So people who have latent TB are people who their skin test or their blood test tells you they have been exposed and they're infected. Their chest x-ray is normal, their sputum will be normal, or negative, sorry. Negative AFB sputum. So they have the TB in their body, but it's not active. They are usually not sick, they are not infective, they can't give it to anybody. But a lot of latent TB will become active at some point. So the higher the risk they are for becoming active, then they can infect someone you treat. If, however, did you talk about multi-resistance and extreme resistance? If they have been exposed to a multi-resistant TB, or an extremely resistant, then they are treated. It's not a latent treatment. They are fully treated. They're treated like they had active TB. Okay? Because we don't want them to become active and then be able to infect. Because we don't have that many drugs, and we want to keep them from spreading it. Okay? So your immune system is really good at suppressing mycobacterium. That's why they kind of hide out. They're intracellular organisms, right? They get in the cell, and if the body detects them, what's it do to it? Walls it off. Okay, like a granuloma, right? You look at an X-ray, you show you X-rays of it, and you got this big open space, but you got this big calcified wall around it. That's the body has walled them off. So we're worried because their potential to infect other people at another time is high. Usually, and the good thing about treating latent is that often it is a lifetime treatment in terms of they're never going to get it again. They're never going to infect anybody again. So we'll talk about who's at high risk and who should be treated. And then do you talk about the health department's role? So it's a reportable disease. You got to call them. They take over and do a lot. I worked with them through family medicine, and they're really good. They got the system set up, and that's what you need. You need a system that is set up to do it, because the treatment is long, months. Can be even longer, can be years, depending on the other comorbidities the person has. What would increase the length of time we would treat somebody? HIV. So often if you've got somebody who's got TB, you might want to think about also testing them for HIV as well, if it's not already known. All right. So in terms of the for latent, we deal with isoniazid and one of the rapamycins, usually rifampin or rifapentine, either one of those. So you talked about directly observed therapy or dot therapy. Yes? Directly observed. Okay, so The biggest thing is that if you treat someone and they get an adequate treatment, they are cured. They are not going to infect anybody else. They're not going to linger and die of TB, which a lot of people did in the past. So we used to, up until, I think when I was in my residency, they started talking about going to twice a week and observing. So you have the option of doing a shorter period of time, less months, and taking a dose once or 3 times a week, but you've got to go in and somebody has to watch you take it. So that's directly observed therapy. Okay. Because it's public health. You know, in our lifetime, we're not, you know, used to it, but my dad had 5 brothers. 2 of them died of TB.
Wow.
So if you go back and read, like if you like more of the English romantic literature, all of those authors died of TB. It was so common, especially in tight quarters. There was no way to cure it. We had sanitariums. We sent people away and isolated them so that they wouldn't give it to anybody else. And they die slow deaths. What do you tell you? 2 or 3 years once you get it? So you're going to die usually of TB if you get it. If you have no treatment long enough, it will eventually get you. So directly observed therapy, you're going to see throughout as I'm talking, you can either do self-administered, usually longer period of time, or a shorter period of time with a directly observed. Okay, so let's talk about the drugs. So MAH is the first one, been around for decades, probably 60 plus years. So it tells you that it has a fairly narrow spectrum. There is resistance in the world to it, but for the most part, it has maintained its efficacy against Mycobacterium. It's one of our best because it attacks the wall. And all of these drugs do that to some extent, except the rapamycin's not as much. But they're good against intracellular and extracellular. So if they're dormant and they're hiding out, we can still get them. They're considered bactericidal. This is important because initially we're going to use, in active TB, we're going to use 4 drugs. And then after 2 months, when those sputums come back, because it takes a while, it takes about 5 or 6 weeks to get, because they're slow growing organisms, it takes a while to get back the pathology. Then we can drop off all the drugs except the INH and rapamycin. That's because they are bactericidal. We drop off the bacteriostatic. Okay? So in latent, we're just going to use bactericidal. The rapamycins and INH are bactericidal, so we're going to use them. We're just going to slam them. Get rid of them. Okay. Okay. All right. So next page. So it reduces the incidence of TB by 60 to 90%. It's very effective. The lower range there is usually attributed mostly to non-adherence. That's huge in TB because they have to take the drug for months. So shortening it down, the period down, is important. And they've got it down to just pretty much the shortest period of time. So we can use it with latent and you can use it with active. So it's another way to consider the drugs: cidal, static, latent, active. Contraindications. If you look here in the middle, 3 of the 5 are about liver. This drug, it causes a severe hepatitis that can kill you. So if you've got elevated liver enzymes to start with, you've had a history of hepatitis, you've had a hepatic injury in the past due to INH, we can't use the drug. And then if they've had hypersensitivity. Hypersensitivity and GI are hand in hand. Any drug can cause GI upset. Almost any drug can cause a hypersensitivity reaction. So those are kind of givens that we're not going to use it. Dosage forms, multiple ones available. The dose you do not have to know, but know that it is based on weight, based on age, and it's based on frequency. So we give, if we're going to give it twice a week, we give a bigger dose at once than we do if we're going to give it every day. Kids, same thing, age and weight. If you look at page 21, I'm not going to ask you these, but here are all the doses, so you can see. You can see what happens if you dose them once a day, or once a week, twice a week, 3 times a week. The recommended duration, now in your mind you have got to get, am I talking about latent, am I talking about active? It's different. So for latent, if you're just going to use INH by itself, you're going to treat them for 9 months. You'll see some recommendations for 6 months, but standard is 9. Take on empty stomach, most people do fine with that. Drug interactions. For INH and rapamycins both, lots of drug interactions. So anytime you would add something to a regimen that had those drugs, you would need to think about drug interactions. If you were going to add these drugs yourself, you need to look at what else were they on and where am I causing problems. So 2 notable ones, phenytoin and carbamazepine are both drugs that we use mostly for seizure control. Both of them have big effects on the P450 system. So INH can increase phenytoin concentrations. And guess what? Phenytoin has nonlinear kinetics. Okay? So if you add INH on, then your serum concentrations go up, so toxicity becomes a problem. You can use them together, but you have to monitor serum levels and you have to adjust the dose. Carbamazepine, potent effect on the liver, potent effect on enzymes that metabolize drugs. So with this carbamazepine, it decreases, it increases the hepatotoxic effects of INH because it decreases its metabolism. So that's a lot of these drugs that are very potent. They can be a substrate and something can affect its metabolism, or they can also affect the metabolism of other drugs. And INH falls into that category. Okay, so I know that you all are started using Hippocrates for your drug interactions because I get questions from you. So I'm going to show you in terms of in a drug interaction program, and most of them are going to do this regardless of whose product it is. But this is Lexicomp. It is, or Lexa, I think they call it Lexa Interact, but it's part of Lexicomp. It's another drug information program that you can buy. It's a pretty good one. It's similar to Hippocrates. Has this drug interaction one with them. So here you can enter in the name of the drug. So we'll put in isoniazid. And we'll add in, we'll put in carbamazepine and see what it says. Most of the time, this is what a drug interaction program is going to tell you. See all those little XD, what do they use? ABCD. Okay. So usually they're going to tell you, right off the bat, it tells you need to monitor therapy. So it tells you there's a major interaction going on there. X would be never use these drugs together. D would be, well, you can use them together, but if you've got something else you can substitute, you really ought to go that way. A would be no known interactions, and B would be, okay, they can coexist, don't worry about it. That's for this program. Then the next thing they'll do, okay, then they'll usually give you, so they gave you a risk rating. Then most of them will summarize and say, okay, here's what the interaction looks like. This one enhances the hepatotoxicity of isoniazid. Isoniazid may increase the serum concentration of carbamazepine. Should tell you severity. So this one's moderate. I would pay attention to a moderate severity interaction. It also, you always need to know onset. How fast is it going to occur? Is it going to occur right away? Okay, then I need to do something before I even start the drugs, or is it delayed? So delayed, get in trouble because they forget about it, or it doesn't show up for a while. Amiodarone and warfarin are that way. You get an immediate interaction, and then you get one that comes out about 2 months later. So that's important. Reliability rating usually will tell you how much literature is behind the interaction. And then they should have a patient management. They should give you some advice on what to do. This one says monitor for increase in carbamazepine and increased hepatotoxicity due to the isoniazid. Then usually they'll give you a summary of the literature. The better ones will. They'll give you case reports, or they'll tell you something. They may pull out one case that was notable, and that's what's in this section. At the end, it should annotate it for you. It should give you literature support that you could always go and look up if you wanted. Okay? Those are the ingredients of a good program. If you've got that kind of information, you can make decisions. Okay? I haven't looked at Hippocrates, so I don't know if that does all of those things or not. Kate, you looked at them. What does it do?
I didn't look for all that. You can like look at it.
It what?
You can compare it to like every drug, but
I don't think it gives a
doesn't have,
rating.
like a- yeah,
Because
it's
it won't have
not
each
like-
individual drug, but it just gives you like a list of its side effects.
I think if you
I
buy
guess
it,
there's a-
then you can do it, but we have like the
Oh,
free
yeah.
Free,
version.
yeah, that's true. They do have one, a license you can purchase. Okay. Okay. All right. So monitoring parameters. The big one is you've got to monitor liver enzymes. So you see ALT and ASTs, those are serum transaminases. Y'all talked about those in lab medicine?
No.
Okay. These are intracellular enzymes in the liver cell. So if you damage the liver cell, if you kill it, it spills its guts, and we can measure it. So it usually, you always have a small amount. I don't remember what I'm giving you is not exact, but it's usually in like the 5 to 35 international units per liter, I think is the. So you always have a little bit. You always have cells that are dying, and so we pick up on that. Okay. So what we're going to look for is you got to have a baseline. You got to know what were they before I ever started the drug. Then periodically, every few months, or if you're worried, you might do it more often, you're going to redraw those. Let's say we had somebody who had a level of 30 before we started. Let's say the next time they come back, it's 75. Okay, so we ask them, feeling bad? Ask them the symptoms, because we've told them what the symptoms of hepatitis are going to be. Have you been feeling bad? No, don't feel a thing. Okay, so we're just going to watch this, because we're not going to start getting really nervous until they're 3 to 5 times higher. I think in your handout I put down if they are not symptomatic 5 times higher. So let's say it came back at 170. You'd have to stop the drug. Let's say they come in and they're symptomatic. See, they came in and they're 92. Now they're 3 times above the level of normal, and they're sick. Yes, I'm nauseated. I just don't have the energy to do what I usually do. I just feel sick and tired all the time. Those are symptoms of hepatitis. So if they're symptomatic, we have a lower threshold. If they're not symptomatic, we have a higher threshold. Some people, depending on whether or not how comfortable they felt, they might continue it and have them come back and recheck, because these things go up and down. But that 3 times with symptoms, 5 times without symptoms, you need to consider changing the drug or moving to something else. Yeah.
Could you just quickly describe again one more time how that's measured? The liver cells are being damaged, and that's what it's showing?
Right, so hepatitis means what? Inflammation of the liver. So you have caused some kind of damage to the cells. So they'll die, and they'll start leaking. And so they leak their intracellular contents. Those ALT and AST, serum transaminases, are intracellular enzymes. So we can measure those. Okay.
Thank you.
Very important that you educate people to what the signs of hepatitis are when you start the drug, or if you're seeing them and monitoring them. So they're very nonspecific, but they're fairly dramatic. They will be sick to their stomach. They won't want to eat. Fatigue is more than I'm just tired. I just can't do what I usually do. I get up and I try to wash the dishes and I have to go back to bed. So it's overwhelming fatigue. Liver's right upper quadrant, right? So they can have pain in that area, complain of right upper quadrant pain. They may lose weight because they won't eat or don't want to eat much. Okay. Next page. Most important side effect of INH is hepatitis. It's important because it can be fatal. And it can occur after they've been taking the drug for a while. Usually occurs in the first 3 months. Usually occurs in the older patients. You'll see it's 50 to 64, I think, is the age group they give it the higher risk. The other are those who use other drugs that would damage the liver, alcohol being the number one. So we tell people, don't drink. If you're on INH, don't drink. Don't drink alcohol. And then monitor those ALT, AST, teach them about the symptoms, ask them about it every time they come in. The other is that they need to know if these symptoms occur, they need to seek medical help quickly. So they need to call, or they need to know where to go to say, this has come upon me, and I'm on INH, and so that someone can check their liver enzymes. Okay, number one. The second one is not so much is a more reversible problem, but one, because they're going to be on the drug for a long time, they can develop a peripheral neuropathy due to a pyridoxine deficiency. So INH competes with B6 as a cofactor in a lot of different enzymatic reactions. So people who, so a peripheral neuropathy, so peripheral means what? Right, so it's away from the body, it's peripheral. So think stocking, glove. So think hands and feet. So those would be the most common. Usually the one that's most affected are the longest nerves, and that's usually the ones from the core to the toes. It's very important with people with diabetes because that's one of the common complications due to diabetes is neuropathy. People who have kidney disease, the uremia, are also at higher risk. Alcoholics at higher risk. People who are not or malnourished, or those with HIV. So I would say it doesn't hurt anybody to take 25 to 50 milligrams of pyridoxine a day. So I would just put everybody on it. So it's preventative, very important. So that is an important one to remember. Hepatitis, most common, more fatal. Pyridoxine, everybody should get it supplemented. Especially moms that are breastfeeding with INH, the baby can get it. So we'll even supplement a child, or an infant, sorry, breastfeeding infant. Okay, questions about INH. Cornerstone of treatment, really important to know that one. Okay, rifampin. So rifampin, there's 3 of them in this category. We're just going to talk about 2 of them though. Rifampin, refabutin, which we're not going to talk much about. It's very similar to the others, it's just not as potent. And then the rifapentine. These drugs work a little bit differently. If you look at that picture, they are very powerful because they inhibit transcription. So whatever the nucleus of that cell is able to produce in terms of proteins or anything for that cell, this drug will interrupt. So the cell will die. Can't make energy, can't produce proteins, can't repair itself. So they're very important. They're very, very powerful. They are good with intracellular organisms. We can use them for latent or active. Okay? They are core. So rifampin, isoniazid, core to treatment of TB. Let's see, contraindications, not as much hypersensitivity. The second one, concurrent use of antiretroviral or protease inhibitors. So this is a problem because that's what we treat HIV with. Rifampin is a powerhouse. When you see rifampin, you have got to think that drug can do anything it wants to the liver. It can tear up any drug you try to give somebody with, it will inhibit. Powerful drug, multiple drug interactions. Red flags ought to go up in your brain whenever you see rifampin, or if you're going to add it. We don't use it that often. We use it a few things outside of TB. For prophylaxis, against certain meningitis, we do household contacts, but otherwise you won't see it very, very often. So it will increase the metabolism of those drugs, and so what happens is you get treatment failures. So their CD4 counts will fall, their immune status will become imperiled because the drugs won't work. So in terms of latent, it can be given daily, or it can be given by direct observation as well. You'll see there it's a weight base for kids. You'll see a lot with these drugs is that the weight base for kids is higher than the adults, but the maximums still are in place. Okay. A little bit different. In terms of monitoring parameters, these drugs can also cause hepatotoxicity. They're just not as terrible as INH. If you look under adverse drug reactions, there's the most common and then there's most notable. So most common is rash. Any of these drugs can cause a rash. Any of them cause GI upset. Very common is a flu-like syndrome. And they will come in and they will complain of everything. You'll think they have the flu. They get lethargic, they ache all over, they don't want to get up and do anything, they don't want to eat. Those would be a flu-like syndrome. CBC changes, you can see any of the cell lines affected. White platelet, red blood cells. Most notable is it will color any secretion you can make red. You have to warn people because it is like Ceftonir. If you don't, you'll pee red, you'll poop red, you'll cry red. So they will discolor their contacts, so they cannot wear their contacts when they're taking rifampin. Their dentures, their saliva will be red, and so their dentures will turn red. Or if they have other prosthetics in their mouth, that will turn red. Anything can turn red. So you need to warn them. Pharmacists should warn them also. Helps if you warn them as well. Potent 3A4 inducer. Lots of drug interactions. You see that little red flag? You're going to see me throughout the curriculum put this by some drugs. Amiodarone will be another one. Anytime you see rifampin in your brain, a red flag ought to go up and you should think, I got to go look this up. Or I need to talk to a pharmacist. And they can give you that information if you don't have it at your disposal, or if you need help interpreting it. Find them out. Now in pregnancy we can use INH, but we don't use rifampin in INH and rifampin in pregnancy unless the risk is outweighed by benefits. They recommend not using it in breastfeeding women. If you look at the data, it's all over the place. Some children, breastfeeding moms that are taking rifampin have elevated liver enzymes. Some children are treated and have no problems. Some children infants are born to moms taking rifampin and there were no problems. But it's very controversial. So the recommendation is not to use it if they're breastfeeding. Did y'all have a question?
No, ma'am.
Okay. So that's rifampin.
He did mention in his TB lecture, what if apparently he does get TB? Like what's the complications for the baby?
Baby can get TB, they can be born with it, so you're gonna treat. And usually the treatment's longer, I think treatment's 9 months, a little bit longer. So then they would treat the infant as well. Okay, rifampin. So this is very similar to rifampin, they're both in the same class. This one has a longer half-life, a little bit more potent. So you may see it. It can't be used in kids under 2, but for the most part, you can think of it very similar as you do with rifampin. If you've got a rifampin-resistant bug, you wouldn't use this. It would pretty much knock that class out. Not going to use it in pregnant or breastfeeding women, so very similar to what we saw with rifampin. Can use it for latent, can use it for active, both. In terms of dosing, very similar. It's based on weight. They all have maximum amounts that can be used. It can be used with direct observation. This one can be used once a week. If you do it once a week, it has to be under dot. So that makes it very powerful when you can get away with once a week dosing. Adverse reactions are very similar to rifampin. The only one is at the bottom, is different. Because if you give a large dose, this is associated with just the once weekly dose, is that hypotension and syncope. So you know what syncope is? Okay. Usually it's due to an arrhythmia. You have a arrhythmia, can't get blood to the brain, you fall on the brain. Similar in terms of monitoring parameters, also has a lot of drug interactions. So the big things that are different, longer duration of action, once a week dosing available. Can't use it in kids under 2, hypotension and syncope. Those are the big things that are different.
Does it only not work on latent TB in children, or could it work on active?
You can't use it in kids under 2.
Okay.
Okay, we're going to go through this page and the next, then we'll take a break and that'll finish up latent, and we'll come back and talk about active. Okay, so this is still latent. So the preferred treatment is INH. Either they can give it themselves for 9 months, or they can use weekly INH and rifampin for 3 months given by direct observation. So you have to drive somewhere and have somebody watch you take it once a week, but you only have to take it for 3 months. Alternatives are INH for 6 months, INH plus rifampin for 3 months, or rifampin for 4 months if you've got an INH resistant bug. Okay. So latent's easy. It's either INH or rifamycin, and you've got multiple ways to dose it. In pregnancy, the regimen of choice is isoniazid for 9 months. Don't forget the pyridoxine. An alternative is using rifampin for 4 months. I think there it's probably going to be an ID call. You know, once you get into resistant bugs, then you really need an ID person who's helping and advising. It's monitoring for the hepatitis again. Other side effects the same. For kids, INH is preferred. The big thing with INH, or the big thing with TB in kids is adherence. So knowing and working with the family on how are you going to set it up to remember to give the drug. Rifampin can be used in kids older than 2, has to be under DOT. And rifampin is an alternative. For HIV, so that's your pregnancy, your other special, or children, special population, another one would be HIV. So HIV, again, INH is the recommended for 9 months. That says resource rich. So that's where people have the money, they have the resources to get to the doctor, they'll come in for lab. Those are people who have resources that can be attributed or go towards healthcare. Resource poor is can't afford the drug, don't have a car, you're moving around a lot. So those are where you would look for an alternative. So here is 6 months up to 36 months.
Why would you do it long? It seems like longer would be harder for someone.
Because you'd have interruptions.
Just to make sure they got it.
Yes.
Okay.
So we're going to get to that concept in a minute about interrupted therapy. Drug resistant, then, and again, we're still talking about latent. If they have INH resistance bug, we're going to use rifampin. If they have a rifampin resistant, we're going to use INH. If we have resistance to both, then we're going to go with the alternative. So fluoroquinolones are part of the alternative group. Fluoroquinolone plus ethambutol or ethanamide. Here, longer duration, up to 12 months. Okay, that's latent, so not many things to think about. Yeah.
We learned with this morning that
Yeah.
you're supposed to get like a 4-drug regimen so that they don't become resistant.
That's active.
That's only active.
That's active. Okay, so that's why you gotta separate them out, so latent, active. So active, you start with 4.
Okay.
You do. Okay, so the next page 9, these are reminders. Monitor for drug interactions anytime you've got a rapamycin on board. Hepatitis, don't forget it. Advise people don't drink and educate them about the symptoms of hepatitis. Remember the upper limit, so 3 times the upper limit of normal for the ALT, AST. So upper limit of normal, so this is considered normal. This would be 3 times this upper limit. That's the upper limit, 35. 3 times with symptoms, 5 times asymptomatic. Supplement with pyridoxine for your INH. Interrupted therapy. So let's see if I get it for this. Okay, so interrupted therapy. So that becomes a real problem. The earlier the interrupted, let's say something happens, they move, they lose their insurance, something happens and they can't get in, or they drop from interacting with the healthcare system. If the interruption is early, then that's more of a problem because they haven't gone to a negative sputum yet. They still got bugs that haven't been killed off yet. So the earlier and the longer has a more serious impact. So when you're looking at interruptions in therapy, you look at where is it occurring, and then the decision is, do I go back and start all over again? Because sometimes that's what we do. Or do we just pick up where we are and finish it on out? Okay, those are the 2. So that interruption of therapy is a big concept to keep in mind. When, how long, do I go back to go, or can I keep going? Okay. All right. So if they're in a 6 to 9 month regimen and they miss more than 3 months, then they go back to start all over again. Clock restarts. For patients on a 3 to 4 month regimen misses more than 2 months, then we go back to start. Otherwise, they'll continue. And what they'll look at is how many doses did they need to get. And then they'll look at that number of doses needs to be done in a certain time frame. We'll see that when we talk about active, and I'll show you it in the table. Okay, let's take a break and we'll start back at 2:30. Yeah, we're just here, either way. No problem.
It's not in direct observation.
Oh, I don't know how they dismiss.
If it's direct, is it kept at the facility?
Yes, yes. I don't have, yeah, I don't have to do that.
Oh my god.
They just show up.
All the nerds.
It's like that limited resource that they can't come in.
That's the problem.
I guess y'all got this half right.
Yeah, pretty much.
Would you like the red? I wanted the
I just want to
upstairs. They're really thick. Not necessarily, you could just be, like, let's say you're not.
I never talked to Jerks about it because after that, we're not supposed to do anything. We're supposed to
Could be
submit our
they're
cases
using it as
and have
lots.
them, or to the health department and have them make all the
it's like,
That isn't
it's,
necessarily related to
But
that.
I think we're probably, it's active, so we're probably
Probably
supposed to
other
be the board of
factors.
regimens, but I was.
it seems like you
Is that
would,
your?
but you don't do it because it's
your
not
experience
confirmed
that must
yet,
have
but like,
been
that's my point, is like, I don't understand when you.
Like, when is it officially diagnosed?
Yeah, like, because if you just suspected, if everyone did that, just suspected it.
Yeah, because
everyone
based off your
figured it out.
results, if you just have like the lung, like that's not confirmatory. I have a blood test in lung, but she just said that the blood test
What's your blood test?
it was positive.
For TB?
Yeah.
What's
But
the test?
I just ordered a blood test for, it's, there's two different kinds.
So you, I
The
didn't know.
T-spot and the
Right, the ones
quantum
that got
gold.
last hour?
Yeah.
How'd you know to order
I looked them up online, because I looked up the sputum sample and it said it took 8 weeks, and I was like, how are we gonna get that back to diagnose our patient? So I put a note, I go, sputum sample is not back, I want one of these blood tests to determine,
Wow.
because the blood test comes back in less
See,
than
here
22
it's not
hours.
so much because it's considered a public.
So when I wrote her my request, like I
Yeah.
requested
Right.
the sputum sample, and then I put, if sputum sample is not gonna come back, I want the blood test.
And get their.
And so she said sputum sample pending blood test positive for TB.
This is like,
But the thing is, the
I wish I
positive
would've
only
had
confirms latent. It doesn't necessarily confirm active, like it just means that you have it in your body, and so,
so treatment is still tough.
yes, we would need, I think you have to get the sputum sample to confirm. So treatment is tough because you can't prove that she has it.
I like thinking about it after.
Yeah,
I
yes, I
can't
do.
Oh, I just put it.
Have you already turned your nose in?
No,
Oh,
but
okay.
like, you know, I can't order another
Oh,
test.
that's so
Right,
sad.
right. Well, that's the thing
Or
is,
even ask.
I think if you had even ordered another test, like, it wouldn't matter because the sputum sample is gonna take time to come
I
back.
have noticed, like, when I, at the.
Well, I mean, we did order sputum.
Right, but we can't determine the treatment path.
A lot of them just weren't in good health. And they were, I would say most of them.
And the other thing is, this is so vicious, like this medication, that you don't wanna put them on it if you don't know they have it. So I'm gonna go talk to Brooke.
When she's on,
Blood pressure med too.
yeah.
So yeah, we're gonna look at both of those. Yeah, I was gonna talk to Latassi and Brooks after class and see. Okay, yeah, absolutely. Yeah, it's not something to just like play around with.
Tricky.
It's like a vaccination. So, yes, yeah, I have that too. My mother gave it to me under my. Wow. Okay.
Well, I was on that side, so my score was.
So it looks like,
Make sure.
which I'm surprised is. But I don't think most people exercise actually do it. There's here even at $9. Yeah. be that it was fairly because I think the average is like 2 to 3 years. Just to get some people. Well, and
But she's getting more of them, so I'm keeping them.
In the like halfway.
Yeah. I'm trying to get married up a bit.
I don't want to wait.
I'll probably get married on my 30th. So.
Well, Will, I'm on the verge of a very long journey.
Exactly.
So,
So you have 70.
you're going to be working, and he's not even going to be going to
I'm going to be working, but he's
You can start with
I think my on my own is going to take me long.
Well, I understand. I send directly to I'm gonna have to test everything. Did you have a person with that? Not using it. Oh, our person has TB and we're like,
I really want to see Tiger was coming back.
nothing's like confirmed yet. We just have like x-rays or
He's actually coming back.
that. And I asked the guy today, I'm like, what do we do? And he was like, you don't treat them. Like you're sending them to us and we don't treat them. Yeah, so I don't know if we could refer to Oklahoma State Department to get treatment.
Well, what we tell her when we go in is go home.
Yeah.
And then we call the state. So I guess that should be in our plan. Although I don't know if that's in our plan to.
I was thinking in the plan, but I'm like, do we put her on medication to get the blood test confirms latent, but doesn't necessarily confirm active.
Right,
And
but
the chest x-ray doesn't confirm anything.
she said that the chest x-ray was usually normal on late. So we don't know if it's like post being infectious, but we talk about like having a scar
And
and
like,
stuff.
if you just have the x-rays, you don't prove that it's not lung cancer or that it's not pneumonia. I would say TB, but you don't have any diagnosis because he was saying, you know, a lot of people say it's advertising pneumonia or that it's something else. And so I'm like, based on the results we have, like, mine's a little bit more going to inside the blood test for that. And these are not, I would say these are not drugs like mine. You can put someone on it if you think that that's something like you want to make sure.
Yeah.
Yeah, I'm gonna go back to
I forgot because that's confusing. Yeah. Especially not. I mean, definitely in your case, but especially in our case, especially the people who didn't smoke so much and don't have like that.
yeah, like you definitely shouldn't
Really
have done
don't
any
know. Like
medication.
you really shouldn't. And but if we're suspicious, we shouldn't just leave them.
Right.
Not do anything. So it's like I know I'm definitely gonna put in the end like and wait for it.
Yeah, and you can have them contact Oklahoma State Department as well. Like you don't have to wait for them. They can
Right.
contact them. It's just
Well, yeah,
you tell them to
yeah.
so that they don't.
Right. Yeah.
So yeah, I don't really know what to do. So I'm gonna go talk to them.
Yeah, good. Because I was thinking that she was like, so now that I'm thinking already plan, I was like, I wanted to wait until today because
Because I knew we were gonna cover it.
So I was like, I don't know what to do with that. I'm like, probably gonna go further because some weeks, like, that doesn't seem like a PCP type of situation. But yeah, it just got more and more complicated as we went on.
And I don't know, like one of the groups that didn't do the blood test, because what she's gonna tell me is gonna be different from what she's gonna tell you guys.
Right.
Because mine's more confirmatory.
Right.
So, but with you guys, I would definitely not have you prescribe me medication.
Right.
So,
But yeah, I mean, if we have, but then he said also like if you have a hunch that it could be TB, still want to try to cordon off and contact the health department because I'd rather catch it like whoops, than not. So no, it hasn't.
and the treatment's harder than the case itself.
looked at Wish. I didn't know if it was one, so I ordered like something that was like 50. My old like we forget to but it would take like I just ordered it. My old but the only thing is sometimes it would take like a month to get right. It's kind of yeah. I used to make people like whoever's making it may take longer. Yeah. They have an hour to act. It's weird. I literally did a step back.
Let's pick back up on it.
You gotta what? I got the blue one.
Okay, so that was latent. So switch your brain over to active. So these are people who've got they've got a skin test positive, chest X-ray shows something. You're going to get AFE. You're going to do a smear, and you're going to send away for culture. And at least when I was doing it in Austin, it was 5 to 6 weeks. Did he tell you how long it takes to get it back? It's a long time. So
he said immediately.
He said you send it in now if it's an important case, so you'll get in within like
Like
5 minutes.
lunch
You send it in the morning.
For the senior health department.
okay, wow, that's fast.
But most places.
I thought he said that sputum it was 6 weeks.
Smear different than a culture. He didn't really say
Yeah,
that.
yeah. I think they can just look at it under a microscope and see if there's any. And then what they do with the, when they do a culture and sensitivity, they grow it out and they see is it resistant form or not. Okay, so here we're going to use. So the direct observation becomes important, as it was in the other, and it's really considered the standard of treatment, is to do it under direct observation. Reportable disease we talked about. So we divide the treatment into initial or, they have another word for it, intensive phase, and that's usually 8 weeks, and then you do a continuation phase. So the first phase is 2 months, and the last phase is anywhere from 4 to 7 months. So your total is usually, for most people, is 6 to 9 months of treatment, total. Okay, so initial phase, you talked about 4 drugs, you use 4 drugs in the initial phase. For almost everybody, unless you have a reason not to use, like pyrazinamide, is usually the one that they don't use. Yes.
Is this only the HIV?
No, this is everybody. HIV uninfected. Sorry. I'll give you snippets on HIV patients, but most of these are the non-HIV.
So we'll start with 2 months and then you do one of the regimens?
You're gonna start 2 months, you're gonna use INH and rifampin, your bactericidal. Then you're also gonna use a thiambutal and pyrazinamide. They're bacteriostatic. You can do that for 2 months. If you look at the next 2 pages, these are taken out of the American Thoracic and the American, the Society for Infectious Diseases. They put out a guideline in 2016. I posted it to D2L. It's under the TB section for you. Okay, I took these 2 out of there. So the first one is the regimens, and the next one is what do you do with interrupted therapy. So if you look at the table on page 11, they've divided it into intensive phase and a continuation phase. Okay. Then you look down, there's 4 regimen types. I think he said in his, I remember they used 2. Regimen 2. Could be wrong, but I thought that's what his slide said. So if you look through the intensive phase, every one of those regimens has how many drugs? 4. So, and then you'll see for each of them, it may have a different interval and dose. So 7 days a week for 56 doses, or 5 days a week for 40 doses for number 1. Next one, if you look, is about the same. The third regimen is 3 times weekly for 24 doses. And the last one is 7 days a week for 14 doses, then twice weekly for 12 doses. So there's different ways of going about. When you get to the continuation phase, you're dealing only with 2 drugs. You drop out pyrazinamide and you drop out ethambutol. And you see 7 days a week for 126 doses. Regimen 2 is 3 times a week for 54 doses. And so on. And then it gives you the range of total doses. I'm going to ask you that, but you ought to understand the concept, because they will look at how many total doses have they got, how many do they need, and over what time period does it have to be done. They'll use that in terms of if there's an interruption in dose, is that, so it's not just the total dose, so they need 100 doses. But if it's over too long of a period of time, it increases risk of resistance and they don't get full treatment. So that becomes a concept to look at. So you'll see regimen 1 and regimen 2 are usually the ones that are preferred. You'll see them most common. Regimen effectiveness. Top 2 are more effective than the bottom 2. If you look at that little arrow over at the side, it's showing you greatest effectiveness with those top, least effectiveness with the bottom. Okay. So go back on page 10. You're going to do a drug susceptibility to, they're going to run that, and you'll get that report back, but it'll take a while. If you get it back and it says they are susceptible to INH or rifampin, you can drop out some of the other drugs. Okay, so ethambutol can be stopped anytime, as long as resistance isn't a problem. If they're coming back for retreatment, if they're coming from a country where resistance is high, then you should have a high suspicion that they will be resistant to one or more of the drugs that you have started them on. When INH and rifampin cannot be used, treatment duration goes up to 2 years or more. All right. Yep, we'll get to that. Okay, let's go over to page 13. We'll come back to those interruptions when we get to the continuation phase. So we've talked about INH and rifampin already, so let's look at pyrazinamide. So this is a bacteriostatic drug. It is, in adding it to that initial grouping, allows us to go down to a shortened period of time of treatment. So it has what they call a sterilizing effect, and it makes the INH and the rifampin more effective. So it has been able to decrease the length of treatment from 9 to 6 months for some people. Never use it alone. Resistance is too high. One of the worries about using pyrazinamide with rifampin and INH is that the risk of hepatitis is high. Liver damage goes up a lot when you use these together. In terms of dosing, again, it's weight-based here. You use ideal body weight. When we get to into renal, we'll talk a lot about how to dosing drugs often on either ideal body weight or a modified. For very obese patients, I always use a modified because they usually have a higher muscle mass. The heavier people are, usually the more muscle mass they will carry, and so their creatinine, the amount of creatinine they produce is higher. So if you use an ideal body weight, you will underdose them. So we'll talk about that more later on. But usually, as long as people are close to their ideal body weight, that's what we're going to use. We're not going to use their usual or we'll use an adjusted, modified instead of their actual body weight. Pediatric dose also on weight. So let's look down at the adverse effects. 3 of them are really important. The arthralgias, up to 40%, so that's really high. So, and it's polyarticular, so it'll be multiple joints usually that they will complain about. Uric acid levels go up. So this drug interferes with the ability of the body to get rid of uric acid. What is uric acid? Where does it come from? What? Nitrogen sources. Okay. What else? Hemoglobin? Tell me more.
Just from birth.
You get gout, you have like hemolytic something one time.
You eat a lot of meat. It comes from purine-based foods. So purines are part of what? DNA. So usually high purine-containing foods like meats are usually, I'm not quite sure what you're remembering. I can't make the connection. I don't remember in hemolytic anemia's gout being more of a problem. It can be when you, now one place you can is if you have a high tumor burden and you kill off a lot of those cells quickly, you can see gout come from that. Maybe that's what you're thinking. So uric acid is an end product. So our bodies can't do any more to uric acid than what it is. Animals go ahead and metabolize it further. The only thing we do with it is we pee it out. So if we produce a lot of it and we can't get rid of it, or we can't get rid of it fast enough, it builds up. So it isn't a very soluble molecule, so it tends to like to migrate and get into places that it causes trouble. And one of the places it will get into trouble is our joints. So gout usually is a problem with joints, can also deposit, the crystals can also deposit in kidneys and lead to a nephropathy due to those crystal deposits. So if you have somebody who already has gout and you raise their uric acid levels higher, then the gout incidence will go up. So if people already have, let's say uric acid is above 7, you probably are not gonna, you're gonna have to be careful with this drug. But we can put them on drugs also that will decrease their uric acid production. Hepatotoxicity also a problem. So INH, pyrazinamide, rifampin, that is a big, big burden and increased risk for hepatotoxicity. So contraindicated in patients with gout, I would think that you could use drugs to prevent that, because you're throwing out a pretty good drug when you do that. Okay, next one is ethambutol. Always used in combination, has a little bit different mechanism of action. It also inhibits cell wall synthesis, but it does it differently than INH. Considered to be bacteriostatic. Also weight-based for kids and adults in terms of drugs. We've done an adverse effects. It has a really unusual adverse effect, and it has to do with color perception. So it causes a retrobulbar neuritis. Very important. It will affect their visual acuity, and it will affect their red-green perception. So you want to warn them about this. If they have vision changes, they need to be seen and evaluated. Usually occurs after 2 months of therapy, so most people are going to not use it that long. So that's a good thing. Usually reversible if it's caught early. Can also cause a hepatotoxicity. So you can see during that first 2 months, it's really a high risk. That's why you got to be really serious with people. You cannot drink. You cannot use other hepatic drugs that are going to affect your liver. No significant interactions. Pyrazinamide and ethambutol usually don't cause us trouble like INH and rifampin do with drug interactions. I like this little diagram at the bottom because it shows you where each of these drugs are working. So you can see why they're so powerful. They each work at a different point. So it's like going to battle. If you can hit the enemy in 4 different points, you're much better off with than one, right? So we're going at it from multiple points of view. All right. Questions about those? Those are our other two drugs. We're gonna start with all four of them if we can. So once the continuation, and once we're through with that initial phase, we're gonna move into the continuation phase. For 4 to 7 months, we're going to try to do that with INH and rifampin. Okay, so those who require longer are usually people who have cavitations on their chest x-ray, or they've got a positive sputum culture after 2 months. So after you've treated with the initial, you're gonna repeat their sputum culture. You wanna get it to where you've got 2 negatives, right? Did he tell you that? That's what we always did. So 2 negative cultures is one of your goals. Also, if you could not use pyrazinamide in the first 2 months, pregnant women, you're not going to use pyrazinamide. Or if you've got another reason why you're not going to use pyrazinamide, then continuation phase is longer. So let's look at interrupted therapy. So go back to page 12. Again, this is from the guidelines. They have divided it into the initial phase and the continuation phase. In the initial phase, which they call intensive, if the lapse has been less than 14 days, they went without drug for less than 2 weeks, then it says, look at the approach, continue treatment to complete planned total number of doses. So that's a concept we haven't seen before. So total number of doses, if you look on page 11, it told you, if you are in that, if you're using regimen 1, then you want 56 doses if you're using it daily. Okay? So you're going to keep treating them until they get to that 56th dose. Now, if the lapse has been more than 14 days in duration, going back to page 12, then what are you going to do? You got to restart. Everything starts, so if you're 3 or 4 weeks in, you got to go back to 0. Go back to go. Continuation phase. Received 80% of the doses and they had a smear that was negative. Okay, that's good. So they may just keep treating them until they finish the number of months. If they've got 80% of the doses and it's positive, then they'll continue until all the doses are complete. So go back and look at that. On the table before, it tells you the number of doses or the dose range that they needed to get in that continuation phase. So very different. I can't think of any other treatment that we do this. So those are concepts to remember. Interrupted therapy, what do you do? When did it occur? How long did it occur? And then what are we going to do? Go back to the beginning, or are we just going to keep treating until we get to number of doses or number of or the time? Just going back to page 12 and finishing that up, the third one down on continuation phase, they receive less than 80% of the doses, and the cumulative lapse is less than 3 months. Then the approach is continue therapy until all the doses have been completed or consecutive lapse is greater than 2 months, unless the consecutive lapse is greater than 2 months. If they receive less than 80% and the lapse is more than 3 months, then they go back to 0. Now, do I expect you to know all those details? No, but I do expect that you understand the concept. Okay. All right. You see why adherence is so important? Those things you communicate. If you're not seeing them for that, you ought to be hitting the adherence. Are you taking your drugs? Are you making your appointments? You can call up the health department and ask them and find out. Yeah.
So if they quit taking theirs for more than 2 weeks and we restart from the beginning, does that increase their hepatotoxicity?
It could,
Or
it could.
Okay, so it's not like they stop it, so then it kind of digresses. Does that make sense?
If they had elevations, then they're going to have elevations again,
Okay.
more than likely. So total exposure, I don't know that the concept is so much total exposure, except you do see it even with people who've been on it for a long time. I don't know that that's the only thing that would predict whether they had a hepatotoxicity or not. Okay, 15, back to page 15. Monitoring and adverse effects, let's go through that again at the bottom. This is somewhat a review and a summary. If they're on a thiambutal, baseline, you need baseline vision, you need to be following it up, you need to be asking them, need to tell them if this occurs, you need to call in and be seen. Adherence, very important every time you see them, whether you're seeing them for the TB or not, and you're seeing them as a primary care, important. If they have TB and they are not known to have HIV, probably a good idea to test. Educate them about hepatotoxicity, so if they know the symptoms and they know that it's important to come in for a visit or to call if those things happen. Happens with all the drugs except thiambutal. Those are the big three. Who's most needs those enzymes measured? Abnormal baseline to begin with. So let's say they were 45 at baseline. Okay. They're above normal, you can still treat them. You can still start, but you may want to see them more frequently. They've reported symptoms that are consistent with hepatitis. They have other underlying disease, hepatitis B, hepatitis C. These diseases are commonly in the same person. B, C, alcohol abuse, HIV, and TB. Pregnancy, first 3 months postpartum. Combination therapy that includes pyrazinamide in the continuation phase. That would be unusual. Other situations associated with hepatic injury. So they're put on another drug that is hepatotoxic, amiodarone. They develop AFib and you're going to treat them with amiodarone. That would be an increased risk. Drug abuse. So you're going to ask them what kind of recreational drugs they like to use. And so if that also puts them at risk, that would be important. And then there's the discontinuation rates with 3 times the upper limits of normal or 5 times. Next page. Talked about the ocular, talked about, the rash. Okay. So the rash, so with rifampin, they can get a petechial rash. So you run into petechiae already? Yes? So what lab are you going to draw if they've got petechiae? Platelets. Platelets. So sometimes you get petechiae because your platelets are too low. Sometimes it is due to an immune reaction. So some drugs will cause petechial rashes. So it'd be important to check their platelets because those drugs, the other drugs, can also cause thrombocytopenia. So deciding on whether it's a platelet level problem or if it's a hypersensitivity reaction. Don't restart the drug. It'll happen again because it's an immune response. Drug fever. Drug fevers are difficult to discern. You have to almost rule everything else out. Drug fevers will tend to follow a certain pattern. They won't act like a normal fever. So they're difficult. So it's just something to keep in mind. If they're afebrile most of the time, if there's no reason for them to be febrile, then think about or entertain a drug fever. And often it is a process of elimination. You take them off everything, you keep adding things back in to find out what's the offending drug. Counseling points, we talked about GI, take it with food, symptoms of hepatitis, visual changes, petechial rashes. I have said those things 3 or 4 times now. If you miss those on a test, I will really be upset. Sometimes you all miss questions like, where were you? I know it's a lot of information, but when I repetitively go over something, I consider it important. So pay attention to those. Mark a big circle around them. Okay, so HIV patients. So if they have not been treated, there is a protocol for when to start the TB and when to start the ART therapy. So here you're going to start TB first, and then within a few weeks you're going to start them on antiretroviral therapy. it's a big pill burden. So we want to get them established, and then we're going to add in as we go. I think I said there it's at least 8 pills. It's a lot. Be careful with the rapamycins and the antiretrovirals. Here, that refabutin would then become a more drug of choice because it doesn't have the potential for interaction to the same extent that we see with rifampin. Pregnancy and lactation. Initial regimen, INH, rifampin, ethambutol for 2 months, followed by INH and rifampin for 7 months. Lactation's a problem though, so you may have to make other arrangements. PZA is not that's the pyrazinamide, is not recommended in pregnancy. It's thought that its teratogenic potential is low, but there's not a lot of evaluation. So the recommendation, especially by the World Health Organization, is don't use it because the safety data is not there. Without the PZA in the initial regimen, it extends out your continuation phase. So then your total becomes how long? 9 months. 2 months plus 7 months. We're still talking about pregnancy, so you want to use pyridoxine. The other is that if you have resistant bugs and you have to go to your second line, aminoglycosides you don't want to use because what's their big problem in kiddos? Ototoxicity. Okay. Can also cause, I think I said ear malformation, but ototoxicity. Fluoroquinolones would be one that would have to be weighed because you get those cartilage damage, but that would be risk and benefit because it's one of your big second-line drugs. Latent TB can be deferred until the second trimester. They're not active, they don't have active TB. Most of your organogenesis all takes place in that first 8 weeks, so waiting after the first trimester, it would be after the 13th week, most of those drugs could be used then. Okay, look under kids a little bit different because children tend to carry a lower bacterial burden. Then they sometimes will drop from 4 drugs to 3 drugs just to decrease the amount, make the adherence a little bit better. Treatment is 9 months. Risk of the ethambutol, keep that one in mind. Don't use rofepinim. If you look on page 18, I had made a chart of all of those adverse effects. The ones that I'm holding you responsible for are all the shaded areas that you'll see. The white ones are not. The ones that are shaded are the most common. Gives you the adverse effects, signs, symptoms, and some comments if needed. The next page, I have drawn you out a diagram of just the basics. Where do you go if they're culture negative, agitation negative? Go this way. If they're sputum positive, X-ray is negative, you go this way. If they're both positive, you go this way, and you go this for this length of time. Now there may be other caveats, but this is the basic. Okay? So this would be for most people.
I have a question about that. Dr. Lachappi?
Yeah.
So I'm a little confused. Our speaker kind of mentioned calling the health department.
Yes.
So I got the impression that like we might see or suspect the active TB and then we just send them to them, or do we start therapy, or do we drop?
You won't start therapy, you'll call them because they will work them up.
So we don't actually really manage it?
You know, it's just going to depend on where you are. When I was in Texas, we managed a lot because we saw them a lot. The health department might say, this is it, here's what you need to do. Of course, that was years ago. And so it'll probably depend on your local, where you are and what you're, because if you're in Poda, if you're in Godibo, then they're not going to drive up here. So I think you absolutely have got to contact the health department. And then, based on local, I think they'll direct you from there.
Would we go ahead and order all the testing?
No, usually, well, I'm going on what we did in family medicine. If we suspected TB, we contacted the health department, and they took it from there, and then they came back and told us.
Okay.
So, because then we would mark it, because if they came in, then, and then we were their primary care, then there had to be precautions taken to protect staff and everybody who saw them.
Okay.
So they would use certain masks and respirators and all things like that. So, but if you're in primary care, you will see the people on it. So you've got to know, so if they're calling you about the hepatitis, you've got to know the stuff. But for you starting and making those decisions, no. I saw a lot of HIV patients when I was at family medicine because a lot of them end up with diabetes. So my biggest thing is, are you still taking your medicine? Have you fallen through the cracks? And then my job is get you back into the care of the people who know what to do. So all of this, you may not do it from start to finish, but you sure ought to know where they are because you may be the person who gets them back in. Okay, you haven't had your TB drugs in 2 weeks? Okay. I'm going to call them and let's figure out what you do from there. Primary care, a lot of is looking at through the cracks, where are you? And then hold them back up and getting them plugged back in. That was a lot of my job. The last 2 pages are, I'm not testing you off these, but I'm giving you, I think if you can visually see sometimes how therapy is laid out, it might help you in terms of remembering it. So this one is for latent tuberculosis, that's on 20. And the last one is 21, is for just how the drugs are dosed. So that if it's talking about twice a week, you can look on here and go, oh, okay, I see how they're doing that. Okay, questions? I think if you will, TB is fairly logical. If until you get off into the weeds with people that are multi-resistant or who are HIV and not being treated. So those folks, I've given you some little caveats, and so learn it for the basics, and then know I need help. I need this person to help me. Your IV people will be great. All right. Okay, I will see you, now I see you on Monday for asthma and COPD and our midterm.
One day.
How's the meeting?
I remember all the questions,
Hey Casey. I'm probably gonna text or call you tonight with my stuff. And yeah, no, I mean I have stuff to do before then, but like I was just gonna let you know I haven't finished anything yet. But then when I'm finished, yeah, gotcha. Yeah, I'll let you know. I didn't remember to text you last night with the date of the Good Shepherd, but Paul said he could too. So it's. Do you still like want to switch or? It's okay. Yeah. Do you want to switch? Okay. I just want to. You want me to meet you?
So when do I get it?
Nice to you later.
So that's on Thursday.
Right.
You go on Wednesday because that's when it's changing to Wednesday.
And that's the next time to go,
Yeah.
right?
So you go on the 25th, which is a Wednesday. Yeah, I got so hot.
Dude, I'm struggling.
Were you still like a little tipsy when you got home? Could she tell? Like, was she like,
Yes, I was wondering for our sort of, like, because they're, yeah, just still like, it's like why we're doing any of these courses. Just let them know. Where they saw.
Yeah. I'm thinking
She didn't say anything about it. So I said that to her. I said, okay, you can talk about this. So, yeah.